A very good afternoon, ladies and gentlemen. Today I'll be presenting a case in conjunction with the International Laboratory Medicine Case Contest. My name is Dr. Lee Bisan. I'm from University Tunku Abdul Rahman, Malaysia, and I'm a clinical hematologist. The topic of my case is the unexpected relapse of diffuse large B-cell lymphoma. There has been great advancement in the diagnostic tools in the field of lymphoma pathology. However, it remains very challenging and pitfalls could happen. We could not stress more on the importance of engagement in dialogue between the pathologists and the clinicians. The following case illustrates on how pitfall could happen in distinguishing Hodgkin lymphoma from non-Hodgkin lymphoma. This is a 33-year-old gentleman with no previous comorbid. He presents with bilateral cervical swelling for 4 months duration, associated with B symptoms. Initial CT scan shows a stage 2 disease. A biopsy of the cervical lymph node confirmed infiltrations by atypical large lymphoid cells. Immunohistochemistry demonstrated positivity in CD20, CD30, BCL6, and WOM1, with negativity in CD3 and CD10. The final conclusion made was diffuse large B-cell lymphoma, ABC subtype. Patient underwent 6 cycles of dose-adjusted R-EPOCH, followed by 2 cycles of high-dose methotrexate. An end of treatment CT scan showed complete remission. Patient was well throughout the follow-up until 2.5 years later, when he returned with a right-sided chest wall swelling associated with cough and breathlessness on lying. A repeat CT scan then showed an anterior right chest wall intramuscular mass measuring 6.2 times 6.1 times 7.9 cm, extending to the right pleural with multiple enlarged and matted lymph nodes seen. Patient was then immediately started on salvage chemotherapy in view of the symptoms, with the impressions of relapsed DLBCL. Unfortunately, the mass did not respond after the first cycle. The team then decided to biopsy the mass, and the result came back as presence of focal areas of atypical medium to large cells, with prominent nuclear line and minimum cytoplasm, as shown in the H&E picture on the left. Immunohistochemistry shows positivity in CD45, BCL6, negativity in CD20, 79A, CD10, and the Ki-67 was reported as 60%. The negativity in the B-cell markers was interpreted due to the previous chemotherapy, which included rituximab. The impression made at the time was relapsed DLBCL. However, after 2 cycles of chemotherapy, it is still poor improvement. Hence, a second biopsy of the chest wall mass was made. And again, it shows atypical moderate-sized lymphoid cells arranged in diffuse pattern with irregular round to oval and elongated hyperchromatic nuclei and scanty neoplasm. IHC shows BCL6 positive, MOM1 positive, and again negativity in the B-cell markers. Ki-67 was reported as 50 to 60%. The second impression was again relapsed DLBCL. Eventually, patient underwent 4 cycles of chemotherapy, followed by radiotherapy to the chest wall mass. However, at the end of CT scan showed less than a partial response. And this response really puzzled the treating team. Hence, another histopathologist's opinion was sought to relook at all the biopsy samples, wondering if the diagnosis was in fact correct. So when the pathologist relooked at the samples, the first cervical lymph node biopsy confirmed DLBCL. However, the chest wall mass biopsy shows that the large cells surrounded by small lymphocytes were actually positive for CD30, focal positive for CD15, PAX5 positive, with negativity of the B cells markers. The impression at the time of the second chest wall biopsy was classical Hodgkin lymphoma. And when the third chest wall mass biopsy was relooked, again the large cells were positive for CD30, MOM1, and PAX5, although it's heterogeneous, lacking the B cells markers. The impression made from the third chest wall biopsy was indeed classical Hodgkin lymphoma. This slide shows the IHC summary from the chest wall mass biopsy which you could see there is focal positivity of CD15, positivity of CD30, MUM1, as well as PAX5. Hence, with the revisions of the diagnosis to classical Hodgkin lymphoma, chemotherapy was re-strategized, followed by an autologous stem cell transplantation. A post-transplant PET-CT assessment showed complete metabolic response. Patient was well throughout the follow-up, and he was last seen in January this year, which remained asymptomatic. Putting all this together, this case could have been a case of large B-cell lymphoma, unclassifiable, with features intermediate between DLBCL and classical Hodgkin lymphoma, which is also known as gray zone lymphoma. This entity has overlapping clinical, morphological, and/or immunophenotypic features between classical Hodgkin lymphoma and DLBCL. The first biopsy could have been taken from a DLBCL component, and after the treatment, left behind the classical Hodgkin lymphoma component, which will then pick up during the second and the third biopsy of the chest wall mass. In this case, it illustrates how pitfall could happen in distinguishing DLBCL and classical Hodgkin lymphoma. This case highlights there's lack of uniformity between the reported biopsy results and relapsed DLBCL and the patient's clinical behavior. And this lack of uniformity must alert both parties, the clinicians as well as the pathologists. This case also highlights lack of IHC staining performed, for example in this case, will lead to inadequate diagnostic precisions. We could not stress more that collaborative communications between pathologists and clinicians is the key. With that, I thank you.